Nice to see all of you here. Now, when I started as a researcher in Universiti Sains Malaysia a few years ago, I realized that many were not aware about nasopharyngeal carcinoma. And more interestingly, a lot of people were not even aware that they even have a nasopharynx. Now, nasopharynx is a small region behind your nose, as part of the pharynx, located behind your nose. And it can become cancerous. So nasopharyngeal carcinoma affects the nasopharynx. Now, NPC is a rare cancer with very distinct racial and geographical preference. And unfortunately, it is very rampant in Southeast Asia, and Malaysia has one of the highest national incidences of NPC in Southeast Asia. So that's not very good news. And it affects more men than women. Looking at statistics published by International Agency for Research on Cancer, they have placed nasopharyngeal carcinoma as the 5th most common cancer in Malaysia. So it's the 5th most. So for us, it's a top cancer, one of the top cancers in the country. And looking at females alone, is the 10th most common. All right, not as high as breast and cervical cancer, but in men, it's the 3rd most common cancer after lung and colorectal cancer. So it's very prevalent in men. The incidences are high in men, particularly Chinese men. Okay, so that is why it's got very distinct racial preference as well. Now, to scare you a little bit more, now, this is what we are expecting to see in 2020. Now, 2020 is not very far to come. And the IACR statistics, so these are all predictions. Now, they're predicting that we are going to see more people being affected by nasopharyngeal carcinoma. More Malaysians are going to get affected by NPC. Now, for 2020, we are looking at about 2,400 new cases. Okay, so this excludes people who come in with a relapse. So these are new cases, about 2,400 new cases in 2020, and there is no slowing down. 2035, we are looking at about 3,400 new cases. So, and mortality is also not going down. So this is really not good news. So we have to become more aware about nasopharyngeal carcinoma, because the awareness is not there yet. Okay, we do not know about this cancer so much, even though it's one of our top cancers in the country. So we need to get aware about this cancer. We need to know about the symptoms, the treatment options, because NPC is remarkably curable when it's detected early. The cancer is very sensitive to radiochemotherapy. So when patients walk in and they are detected at stage 1 or stage 2, the cure rate is remarkable. We give them radiochemotherapy, we get clinical oncologists giving them radiochemotherapy, and basically they're looking at about 80% cure rate. But when you're detected late, when patients walk in late at about stage 4, this is when we are in trouble. Because these patients, they may not respond well to radiochemotherapy as they would have if they would have been detected early. So they're not walking in early enough because they're not aware of the symptoms. All right? And they ignore the symptoms. They might be having a neck lump. They'll be sitting at home until the neck lump becomes really big, then they walk in. I even had a patient tell the doctor that I was too scared to come to the hospital. And when she came, she was already stage 4. Okay, so with neck lump, she was sitting with that for such a long time. Hearing loss, sometimes you may hear sound in your ear, they'll sit at home as well, not knowing that it could be NPC. So it's difficult to know the symptoms, but we have to be aware of the symptoms. We need to come and get it checked. Because when it's detected early, it is highly curable. But what happens, but we have most patients walking in late. So we need treatment options for them because they are not going to respond so well to the conventional treatment that we have. So we need to improve treatment strategies, we need novel treatment. Now before I go about talking about that, let's see one of the many ways how cancer manifests or how cells deal with DNA damage. Now normal cells, see here, normal cells undergo stress. Cells normally undergo stress. Now stress can be due to various factors, could be due to UV radiation, could be due to oxygen deprivation. But for example, let's say your cells are undergoing stress due to UV radiation. Now what UV radiation can do to your cells is that it can cause DNA damage. Now DNA damage can lead to mutations. Now sometimes your cells can repair these damages. The cells have inbuilt repair mechanisms to repair DNA damages. So that's great. Get it repaired, the cells start dividing again. But sometimes the damage is beyond repair. When it's beyond repair, what the cells actually do is that they activate the apoptosis pathway. Now the apoptosis pathway is one of the many ways how cells die. It's an inbuilt cell suicide program regulated by various proteins. Now these proteins can come together and activate death so that the DNA damaged cells will be removed from the system because we cannot afford to have them. That's the normal cells. In a cancerous environment, again you have DNA damage, but this time cancer cells, they normally don't activate death. They find various mechanisms. Via various mechanisms, they would evade death. Now when apoptosis is not activated, mutations are going to accumulate. When mutations accumulate, the cells are not going to stop dividing. It will go into uncontrollable cell division. Cancer would then keep progressing. Because very little death is taking place. Now what we want to do is that we want to treat these cancer cells so that they reactivate apoptosis. So that these cells are removed from the system and don't go on dividing. Right, so we want apoptosis to be reactivated so that we remove these cancer cells. Right? Now, let's look at the proteins which regulate apoptosis. Now, apoptosis is regulated by a family of proteins known as the Bcl2 Superfamily. Now, Bcl2 Superfamily proteins, the members in this family are quite interesting because some members of this family support death. All right, they activate apoptosis in the cells. Right? And then you have some members which would evade death. For example, to name a few, we have Bcl2, MCL1, what you can see in the screen now. They help cells evade death. So it is as though you have both friends and enemies all sitting in the same house. All right, regulating apoptosis. Now, cancer cells would love to have the pro-survival molecules because the pro-survival molecules are going to help them evade death or stop death from taking place, because the objective of cancer cells are just going to, they want to keep dividing. They don't want to die. So they want to have these proteins in their vicinity. Because these proteins are normally found in higher amounts in the cancer vicinity, they are also ideal targets for treatment. So the idea is, you take a drug, you treat your cells, you remove these proteins away from the cancer environment. Now that is all that's needed. Then you get apoptosis activated because these proteins are there to stop death from happening. So put in a drug there to remove these proteins basically, to inhibit these proteins basically, so that you can push cells to death again. Now, do we have drugs to do this? Of course we do. We've got a long list of drugs to do this. And these drugs are quite specific on what they inhibit. For example, we have venetoclax here. Okay, so venetoclax just got FDA approval, all right, to treat various blood cancers. Now, venetoclax very, very specifically inhibits Bcl2. And then you have some other drugs which would inhibit other proteins. So they're very specific. They just don't go, they are not promiscuous in their targets. They are very targeted. All right? But the question is, can we just go and pick any drug from the shelf and start treating the cells? Can we blindly go, just pick up any drug and start treating the cells? Now the question that we should be asking ourselves is that which proteins do the cells rely on for survival? Because some solid cancers would rely on MCL1, some MCL1 and Bcl2. Blood cancers, blood cells highly rely on Bcl2. Platelets rely highly on Bcl-xL. So we don't want to be picking a drug which would be inhibiting BFL1 to treat cells which rely on Bcl2 for survival, because patients are not going to respond. So we need to know, we need to find out, we need to determine which proteins do your cancer or a particular cancer or cell type is dependent on for survival. And as I say, venetoclax works well in blood cancer because blood cancer cells rely highly on Bcl2 for survival. So you bring in venetoclax, you treat the cells, they would definitely respond. We cannot be bringing in an MCL1 inhibitor to treat blood cancer cells when they're relying on Bcl2. So that's the idea. So that is why you just cannot blindly take any drug from the shelf and start treating cells. Now at the laboratory right now, we want to know which of these proteins do nasopharyngeal carcinoma depend on for survival, MCL1, BFL1. So we want to determine before we start treating them so that we pick the right drug. Now we're doing this, we're studying the proteins that NPC might be relying on using cutting-edge CRISPR-Cas9 technology. It's a gene editing technology that they're using right now to study the proteins that, or the genes that NPC may depend on for survival. And depending on that information, it will assist us to pick the right drug to treat NPC cells. Now we don't want to just stop in the lab. We want to translate our findings in the lab to patients. So that would require intense research. But we've already started looking at proteins or genes that are responsible for NPC survival. Now our vision is to personalize medicine for nasopharyngeal carcinoma. Now right now what we have is that one-size-fits-all treatment. We have 10 patients walking in with NPC. We treat all of them with the same drug. So some would respond, some wouldn't. Now in the future, we don't want to be doing that. We want to go into customizing medicine, depending on the mutations that the tumors are suffering from. Right? When patients come in, we want to study, we want to diagnose what kind of mutations are the tumors suffering from. Because based on the mutation, then we can pick the drug. So we pick the drug basically to treat the mutations. All right? So in that way, patients would respond well because now you're treating the mutations. Now, the cancer could be coming from the same organ. Now, we could have 10 patients, all with NPC, coming from the same organ, but the genetic expression, the genetic signature could be different. The mutations that they could be suffering from could be different. So depending on the mutation, we pick the drug so that we maximize survival, patient survival, and we minimize side effects and just bombarding patients blindly with drugs. So that's our vision for nasopharyngeal carcinoma treatment, because we need more treatment options, right? So we need to move. We need a paradigm shift. We need to move from one-size-fits-all treatment to personalizing medicine for nasopharyngeal carcinoma. Thank you.